Hello, everyone, and good evening. I'd like to welcome everyone joining us tonight. Before we get started, I'd like to bring your attention to the poll that should be on your screen right now. I'll be displaying a series of polls throughout my introduction, so if you could be so kind as to choose the answer that best applies to you, I would greatly appreciate it. It's my pleasure to welcome you all to tonight's Interprofessional Virtual Grand Rounds presented by the American Academy of Developmental Medicine and Dentistry. My name is Jessica Prokop, and I'm a third-year medical student at The Ohio State University College of Medicine, and I'm also the AADMD Virtual Grand Rounds Medical Recruiter. Let's take a look at our second poll. All right, AADMD Virtual Grand Rounds sessions seek to create a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Rounds sessions is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. At the end of the presentation tonight, please stay on with us to ask any questions you have for the presenters. Questions can be submitted through the Questions tab on your grade control panel on your screen. In addition, tonight's presentation can be downloaded under the Handouts tab located on the grade control panel on your screen for future reference or to follow along. And let's move on to our final poll, which should be showing up on your screen now. At the end of the session, we'll send you a link to a quick survey we've made that shouldn't take more than 5 minutes, but it's very important to us that you do fill it out. The feedback we receive through the survey allows us to improve the virtual Grand Rounds experience and also to hear what future presentations you'd like to have us organize. So let me go ahead and close this poll. And with that, I would like to introduce tonight's presenters, Dr. Christopher Hanks and Amy Hess. Dr. Hanks is a clinical assistant professor at The Ohio State University Wexner Medical Center. He's board certified in internal medicine and pediatrics and provides primary care for patients that span all ranges of age and diseases. His academic area of interest is in developing improved models of care for patients with autism spectrum disorder as they transition from pediatric to adult-based medical care settings. He's the medical director of the Center for Autism Services in Transition, also known as CAST, which aims to provide a medical home as well as consultation and support for adolescents and adults with autism as they transition into adult-based medical care settings. Dr. Hanks received his medical degree from Penn State University College of Medicine, and he completed the internal medicine and pediatrics residency at The Ohio State University. Amy Hess is currently the program director for the CAST Center. Prior to her position at CAST, Amy was the site coordinator for the Autism Speaks and Autism Treatment Network at Nationwide Children's, where she was actively engaged in community outreach, clinical quality improvement initiatives, research coordination, and family-centered care development. Amy is active on many boards locally and nationally. She is currently a board member with the Family Advisory Council at Nationwide Children's Hospital, as well as VSA Ohio and the Franklinton Arts District. Amy is also the parent of a very talented artist with autism and his amazing and charming older sister. Tonight, they will be presenting Caring for Emerging Adults with Autism, a Primary Care and Medical Transition Perspective. And with that, I'd like to hand the floor over to Dr. Hanks.
Well, thank you, Jessica, and thank you all of you for listening in. Hopefully you can hear me okay. This is Chris Hanks. I'll be talking first, and then Amy will take over later in the talk. As we get started here, number one, I don't have any conflicts of interest to disclose, but I want to thank AADMD for the opportunity to speak to you today, and of course, we're happy to take any questions as well. I'd also like to thank Bill and Marcy Ingram and the White Castle Foundation, who have provided very important support for our program at CAST so that we can provide the services that we are. I'd like to start out with the case just to kind of set the stage of what we're talking about and bring up some of the issues that come up when you start talking about transition in a medical setting. So this case, Alan is a 21-year-old male with autism and mild intellectual disability. He's presenting to a new internist to establish care. As an internist myself, I can tell you this is a fairly common scenario with emerging adult with developmental disability. He shows up with his mother. He reports that his mother says, boy, his previous internal medicine doctor didn't know what to do with him, and he was discharged from his pediatrician a couple of years ago because he was too old for them and it was time to move on. He graduated high school with a diploma and spent some time in a vocational training program, but after that he kind of struggled to find work, and so he spent the last year pretty much at home with no regular daily activities, mostly hanging out on his computer, playing video games and watching YouTube. He appears well-groomed, he's quiet, he avoids eye contact. He answers some of my questions with short responses, but often takes a lot longer to respond than maybe ideal. He's unable to answer some questions about his medical history. Really, he doesn't know a lot about his medical history, but his mother often speaks in his place. He exhibits some intermittent rocking in the chair, and as the history goes on, he starts pacing around the room, seeming a little more anxious. From a medical standpoint, he's got a history of ADHD, on stimulants previously, but not on them for the past few years. Although his mom notes that, boy, I wonder if restarting him would help him focus, if he were to go back to work. He has a history of some explosive outbursts years ago and was started on risperidone, which is an antipsychotic or a mood stabilizer, quite some time ago. He's been on it for a long time. They wonder if he really needs it or not, but have continued it. Otherwise, fairly unremarkable medical history, pretty healthy overall. On exam, other than being obese and a little bit ticklish on the abdominal exam, he's got a normal exam. When I ask him if he has any concerns, he tells me, quote, I'm fine, and won't give me much more than that. And his mom expresses concerns about weight gain since graduating high school, the fact that he seems more withdrawn lately, doesn't have any friends, wonders if he's depressed, and also concerns about his dental hygiene, he doesn't brush well, and that they need his guardianship paperwork completed and signed, and can I do that while they're here too? And I pose this case not to highlight this is how all patients are, because of course there's a broad spectrum of what we see, but to bring, it's a common scenario that patients need some level of support in the office, and that many of these patients, as they move from pediatrics to adult-based care, are also moving to adult-based settings in school or work or whatever, and the changes there impact their life and their health significantly. And so when we talk about transition of care, this can be interpreted a lot of ways. And in my time doing this, I've discovered that if I'm not careful about how I talk about it, it can really leave us confused and lost. But what I'm hoping to highlight in the talk today is that most of what we do from a medical standpoint is the same whether a person has autism or not, but with some subtle modifications, I think we can provide some better care. And what Amy will bring later in the presentation is the perspective of, I think, the family and the patient, and the experience from that end as transition happens. But I want to start with a little bit of background about medical care for mostly adults with autism, but some of this translates to pediatrics too. And this is a survey done a number of years ago in Delaware, asking primary care doctors how comfortable they are caring for different conditions. And if you look down there, you can see with autism, the minority say they're comfortable, and many say they're not comfortable caring for a patient with autism. And more recent data continues to confirm that this is the case, depending on who you poll. There's still clearly the majority of primary care doctors and other doctors say that they don't feel entirely comfortable caring for a patient with autism, which of course is barrier number one to successful care. This is another poll looking at residents who are in training, with the lighter colored bars being internal medicine pediatric residents, and the darker colored bars being internal medicine residents. And they also, regardless whether they're pediatrics or internal medicine, expressed discomfort with the internal medicine residents. Only about 10% of them said that they were comfortable with outpatient management of a patient with autism. So clearly a huge gap there that needs to be addressed. And there's a lot of ways that needs to be addressed, and we can talk about that more if people have questions. From a demographic standpoint, as we know, the prevalence of autism is rapidly increasing, and And with that, many of these youth are becoming adults. About 50,000 youth each year turn 18. And so some are in the 18 to 21 age range. Most patients are being transitioned out of pediatric care into some sort of adult care setting. Of course, there's exceptions to that. Every location and setting has a little bit of a different approach to this, but there are many adults with autism, entering medical settings, and the uptick in diagnosis and prevalence of autism started about 20 years ago, recognizing that there's many potential contributors to that, but we're seeing a significant upswing in diagnosed adults with autism at this point. And this slide highlights that same thing, the red line showing prevalence of autism as compared to other lines showing intellectual disability, cerebral palsy, and visual and hearing impairment. So, where many conditions are staying stable, autism is increasing rapidly. Couple that with the fact that the health status of those with autism is not great. Some recent estimates suggest that adults with autism are at much higher risk of many conditions, mental health conditions, diabetes, heart disease, obesity, high blood pressure. Pretty much any health condition you can think of is more likely to happen in someone with autism than someone without autism. Now, there's probably many reasons for that, but I think one of the big contributors is the lack of opportunity for socialization, for work, and things like that leads to either mental health problems or societally they're spending a lot of time immobile and not moving much, and that leads to these health problems. That being said, on average, patients on the spectrum are suggested to be dying about 16 years earlier than those not on the spectrum, are much more likely to die of neurologic conditions such as epilepsy, and are also much more likely to die of suicide. So many different risks from a health standpoint. This highlights, as I was saying, the fact that those with autism are much more likely to have many different health conditions than the general population. Epilepsy probably being one that's more specific to autism, but a lot of these I think are lifestyle driven factors. And interestingly, when you look at what contributes to these increased, the increased mortality, increased cost of care, there's some evidence that those with people with autism and other developmental disabilities, even if they have a good primary care doctor, well, if they have a primary care doctor, are still more likely to end up in the hospital for things that would be considered something that can be managed as an outpatient, asthma or congestive heart failure or chest pain. In many cases, they're being sent to the ER or into the hospital when others without autism would not be, suggesting that their primary care, even if they're accessing it, is not meeting their needs. They're also not getting good health screening. Individuals with intellectual and developmental disability are much less likely to be getting cancer screenings and periodic health exams than those without. And so there's a lot of disparities in health care for this population. And so that's kind of where we came in, based on some experiences, both myself through caring for patients and our donors through their experiences. We decided to start what we call the Center for Autism Services and Transition. We started about 4 years ago with a goal of trying to improve medical care opportunities for adults with autism and work on improving the transition process from the pediatric to adult settings. In background, we're located in an academic internal medicine and pediatrics office, meaning that, in my office there's myself and 5 other primary care doctors, all of us boarded in internal medicine and pediatrics. Not all of them are directly involved in the CASP program, although all of them indirectly end up seeing some of our patients from time to time. But we have Amy, our program director, we have a handful of doctors, we've got a nurse that functions as our care coordinator, we've got a full-time social worker. We have a little bit of time from a psychiatrist, and then we have typical medical staff with medical assistants and registration staff and so forth in our office. When we look at our population, right now the average age of our patients is around 21. we have, I think in my next couple slides I'll show, we have a little bit over 600 patients now that have autism. And they come with a wide variety of medical comorbidities, mental health with ADHD, anxiety, depression, behavior issues being our most common experiences. You'll note the data here suggests that rates of intellectual disability are approaching 50%, which is higher than in the general population of autism. I'm not quite sure why that is, but I think it may be because those that have more needs are more likely to be sent to us, and those that have fewer needs are more likely to be cared in a community setting. So as I mentioned, we've continually grown. We're up to just over 600 patients right now, and continue to grow at a steady rate with the prevalence numbers that I shared before. I see no expectation for that to slow down. When we started this program out, the first thing that happened is we sat down with a group of parents of patients with autism and talked to them about what they felt like we would need to make this work. And interestingly, as I talked about it, the things that kept coming up were one parent after another brought up a scary story of my 300-pound, 6'4" son that becomes aggressive in medical settings, and suggesting we need security and lockdown padded rooms and all sorts of stuff that didn't exist in my office. My office cares for newborns, it cares for geriatric patients and everything in between. And so we took a step back and said, well, we can't provide that, but what can we do? And what we realized we could do is build on past experience, and the past experience being that of the patients who clearly have been in medical settings before if they're coming to us as adults. And so we developed initially what was a phone assessment, and now we've moved it to an in-person assessment with our social worker, and it's evolved some, but this is on the right side of this slide, you see the original phone assessment we developed, where we'd ask a little bit about them, but most important things we were looking at was really how they did in prior doctor's appointments, how they did with different procedures, and if there were any accommodations or approaches that we were going to need to take to improve things. And what we found is that about 20–25% of our patients requested or felt like they needed a modification to our, what would be considered a standard visit. And most of that related to the waiting room. The waiting room is a challenging, highly stimulatory environment. It's stress-inducing. They don't like the noise. They don't like the chaos. Many of our patients have said they really struggle with babies crying, which does exist in my waiting room. And so we had to think about ways to address that. There were also those that would say that they, either didn't like needles or didn't like being touched, or didn't like bright lights or the fluorescent flicking lights or things like that. And so what we did is we took that information, and for each person we created an individualized plan. And if it was, I can't handle the waiting room, then, well, do we bypass the waiting room and register and do all the process for a patient in an exam room, which is one option? Or do we have them wait out in their car until the doctor's ready and then bring them in, which we've done? Or in extreme cases, if we couldn't get them in the building at all, do we have the medical team go out to them in the car? And we've done all those things. And with doing, and so this is some of the interventions that we did. Like I said, most of it was rooming patients immediately. Occasionally we'd skip vital signs or turn out the lights, or and there was one case where there was enough concern that we did have a security guard present just to be safe, but we had that person outside the room, not visible, and ended up not needing them at all. And so despite the concerns of parents, what we've found is, number one, if you go into this in a planful manner with a simple plan in place that honestly can be done in any office with just a little bit of forethought, we found that we could successfully care for these patients. And the worst thing that happened was, I think the most damaging experience we've had so far is a patient took a folder off of a set of folders off my wall and tore it. That's the worst we've had. A little bit of information about what else we're seeing with our patients. They're on lots of medications. On average, they're on at least 3 different classes of medications, most of them psychotropic. Many of them are on even more than that. And so, one of the challenges we experience is figuring out how to manage those in settings where sometimes they can't perfectly advocate for themselves or may not be able to describe side effects in the same way of some other patients could. And that's led us to incorporating a pharmacist to sometimes do the medication reviews and help us make sure we're not leading to polypharmacy and other challenges like that. I want to talk for a minute about some of the barriers to care that patients and physicians experience as we care for this, because I think when you talk about transitioning patients into your medical care setting, what you're really looking at are what are the barriers they experience and what are the barriers you experience to providing the quality of care they deserve. And from a patient standpoint, of course, communication is a challenge. Lack of knowledge about their health and prevention could be a challenge. What could be described as maladaptive behavior in clinic settings is often a challenge, although often I think that behavior is not so much maladaptive as that their way of communicating that something is not working for them. Fear and anxiety relating to procedures is an ongoing challenge. And often patients have just been excluded from being involved in decision making and history giving because, number one, as a parent myself, it's always easier to answer for yourself than have your kids answer. And number two, if someone doesn't communicate as well as ideal, it's easy for a provider to start talking to the fluently speaking parent or guardian figure in the room, and the patient can quickly feel isolated. A couple of years ago, a group working with us from the university that we're affiliated with, Ohio State, interviewed a bunch of patients with autism and kind of asked them about what parts of the medical visit are most challenging. And on this graph you see in front of you, or diagram, anywhere the points are higher are points that they suggested were more stressful during a medical exam process. And so things like the waiting room, things like being examined and talking with a physician and talking about treatment planning can be highly anxiety provoking. And the anxiety and the stress and the overstimulation they described as being somewhat like having bees buzzing in your head, and as more comes and more comes, the bees buzz louder and louder until it feels like your head's going to explode. And at that point, they may not be able to communicate to their highest level. They may not be able to understand things at their highest level, and so they may struggle in a setting where they sometimes could thrive. And so with that information, we've taken a lot of time looking at how do we help patients better communicate. And number one is avoiding highly stressful environments like the waiting room if we need to. Number two is making sure they're allowed to communicate in a way that is most easy for them, whether that's written, whether that's using a facilitating device, or whether that's a mix of parent or guardian supporting the patients with communication. Physicians also experience a lot of barriers. As I mentioned previously, lack of training and lack of comfort with the population is a significant challenge. In a recent survey, only 36% of primary care providers said they've ever received any training or some training about caring for adults with autism. And many providers have reported that it's difficult to care for patients with intellectual and developmental disabilities, and some even say they would rather not. And I'm sure, since you guys all work in these type of fields, you've seen this, but it is an ongoing challenge, and I can't tell you how often patients coming to me, regardless of what else I do, they're just relieved that they're talking to someone that understands autism, and with that in mind, they feel they're getting better care. Physicians, interestingly, under-recognize and under-report their experience and exposure in caring for patients with autism. So a high proportion of physicians under-report the number of patients with autism on their panel. And in a survey, myself and a few other people did of residents in internal medicine and pediatrics and internal medicine pediatrics programs, reported that they were equally likely to have been exposed to a patient with Down syndrome as they were to a patient with autism, despite the fact that autism is almost 10 times as prevalent as Down syndrome. And so just that visual cue of Down syndrome that brings it to mind so clearly made them more likely to recognize that they were caring for someone with that. And I think this contributes to the lack of comfort. It's purely the lack of recognition that people have cared for other patients with autism. So how do we overcome that? Well, again, going back to the transition concept, transition won't work if we don't have providers that can provide the care that's needed. And so education has clearly been an important part of that and needs to continue to be an important part of this. And continuing education courses have been shown to improve knowledge and level of comfort of care. And in some unpublished data, we have a higher number of patients cared for with any given condition clearly correlated with increased comfort in caring for it as well. Interestingly, pre-training exposure, meaning knowing someone with autism or other conditions, or knowing someone, having a family member, did not correlate with increased comfort of care in the same way that providing direct care did. And so we need to make sure our trainees are having the opportunity to experience this care. And then we've started looking at, well, how do we support both providers and patients in challenging parts of the transition process? And often, procedures are brought up, whether it's blood draws, vaccines, in the adult world, EKGs, or we have a good number of patients that don't like getting their blood pressure checked or other vitals. And so we've worked a number of different ways. And one of the ways we've worked on this is to develop some videos that are available on our website, which you can see the link to here, that talk through the whole process. The patient you see getting his blood drawn right here is one of our patients with autism, who very kindly volunteered himself to go through this, and supported by his mom and with some of my other staff in the room. And I think several things came of this. We now have some very nice videos that people can review to go through the process and develop comfort prior to having something done. It also provides us an opportunity to educate other medical providers on approaches to these same procedures for patients with autism. And so we've been happy to share this with others. And so in just a minute, I'm going to turn this over to Amy and let her do some talking. But I just want to comment quickly that when it comes to transition of patients with autism, that and transition of patients with any medical condition, there's many approaches to it, and I think the best way is still being determined. But clearly, you want to assess people's abilities in some way or another, and recognize that that this has to come from both the medical setting making changes as well as the patients making efforts to be prepared, and hopefully through those efforts we can make some improvement. And so I'm going to turn things over to Amy here for a minute. Amy, are you on?
Yes, I'm on.
All right, it's all you.
Thank you. Hi, everyone. Jessica asked me to talk a little bit about the family perspective for adults who are, coming out of pediatric care and into adult care, or youth that are also transitioning. And being the parent of a 18-year-old with autism, I'm sort of actually going through that whole process myself. So first, I just wanted to make sure, Chris, do you still have control, or do I have control here?
You should have control. Is it not working?
No, it's not working.
Okay, let me give it back. Let's see. You should have it. Did I take it away? Sorry, everyone, technical difficulties. Okay, if I stop doing things, you'll probably be okay.
All right. There we go. So first, disclosures. I think Jessica mentioned this in the introduction. I am a family advisor for Nationwide Children's Hospital. And I'm also a family advisor for the Autism Speaks Autism Learning Network, which is a national organization. And of course, I am the parent of a young adult with autism. All right, here we go. So I think one of the things I wanted to talk about is, when you start to work with a patient with autism, I think, understanding the family perspective is very important. A lot of times when I talk about my son, Henry, I don't say, this is my son, Henry, who has autism. I talk about a lot of the things that he likes to do and who he is as a person. And he likes to, he likes to do art, he likes to swim, he loves to travel. He's been to, some great places. And I think it's really important to see the patient as a person first. I think in autism, a lot of times we always sort of step in to treat the symptoms, build a treatment package around the individual or a care package. And we lose sight of the fact that this is an individual. So in Henry's case, it's very difficult because he has very limited language. His impact of autism really has impacted his expressive language abilities. So a lot of times people turn to us to talk, to ask questions and give information. So we always try to talk about who he is as a person and always say at the very end, oh, and he also has autism. So we always remind people that autism is a part of who he is. It's not the totality of who he is. I think also when you're working with patients and families, it might be interesting to understand what their diagnostic and treatment journey has been like. For our family, Henry was diagnosed just after the age of 2, right before he turned 3 years old, actually. And there were a few treatment options at that time. So 16 years ago, things weren't as advanced as they are now. And then at 6, things changed a little bit. There were more options. But to be honest, when he was 17, there were a lot more things to think about. And I think one of those things that really came to light was healthcare and his ability to manage his own healthcare, participate in procedures and exams, and do so effectively so that he would have healthcare for life. And it's something that I think that a lot of families should start at a very young age, practicing blood pressure, practicing blood draws, practicing all those types of procedures so that when you actually have to do them, you have that knowledge and experience. Especially for patients with autism, the anxiety of a new procedure or something that could be startling like a shot can be overwhelming, and it can take a long time to get through that procedure if there's not a lot of experience. And one of the things we know with autism is that the more experience and exposure they have to a new environment or to a new learning opportunity, is the more that they have that experience and exposure, the more apt they're going to be able to be successful with that. So again, I think when you have patients in your office, if they're willing to try some things like a blood pressure cuff and they've never done it before, always try it, because you want to keep practicing so that you can at some point have success with that procedure. I think the other thing that is interesting about autism is that, it's not a single discipline environment. When we were diagnosed with autism, when Henry was diagnosed with autism, a lot of things came into our life, like speech and OT, and, we had a medical team, and we had a psychology team, and we had a behavior team, and, and then we had to have a community team, and, and then we had to have a dental team, and there was a lot of people that had to be a part of our life, mostly because you can't approach certain things with autism just in a single discipline. You have to cross over. So I'll give you an example. When Henry was younger, dental exams were really difficult for him. It took us about 2 years for him to actually have a successful dental exam because he found the process so invasive. So we worked with the dental, hygienist, the dentist, as well as our psychology and behavior team, as well as, our family component, so that we could actually put together a package to slowly acclimate him into a dental chair scenario so that he could have, a full dental exam. So while things took a long time, I think our patience is really paid off, because now dental exams are something we can sort of check off the list, and we can do them routinely and move forward. The same with, when you have, I think, in medical procedures. I mean, he's had limited experience in having a blood draw, but he's going to have one someday. So that's the next big goal for us, is how are we going to achieve that in a way that's going to be very typical of any standard patient that walks through the door. So again, when you work with families, remember at some point, they probably have a large team around them. When Henry was younger, I think we counted at one point, and we had about 32 different people that we interacted with on a regular basis who were part of his team to help manage all of these aspects of life. And you'll notice we have a transition team, which is still in play. One of the things I do when I present to different professional groups is I sort of talk about, what is the year in the life of raising an individual with autism look like? So I did a snapshot of when Henry was younger of what our life sort of looked like. And you can sort of see that in a year's time, I went to about 131 appointments. Or as you can see, I spent about 52 hours every week. Or I went to an appointment every 52 hours. I had an appointment every 2.7 days, and I spent 12.5% of my working hours at autism appointments. And they encompass, ABA and OT and speech and all those kinds of things. And this actually does not count any of the sick or acute visits that we did, or as well as the driving time that was involved. So if families are missing appointments, if patients seem to really sort of be hesitant to engage in appointments or set appointments and follow through, you might want to look at the amount of time they're spending in a lot of other aspects of their lives and see if you can accommodate that to some degree. I think one thing that we've learned at CAS too is that when you have healthcare, when you have a clinic, what does it sort of look like for somebody with autism when they walk in the door? I think, and these are some of the shots actually of our clinic that I just took with my cell phone to, again, sort of give some visual aids and visual guidance to some of our patients. So when you check in, what is that format going to look like? And you might have to sign papers or wait your turn in the waiting room. When you go into an exam room, they could be very small. You're going to end up talking to the nurse or the MA. And then other things that are very new, like if you've ever been weighed before, you have to take your shoes off and then stand on the scale. So these are just really simple visual guides that can help you get through, standard procedures in your office that you can use with most patients. These also work really well for patients who don't speak English, we have found as well. So. Potential difficulties for patients and families. I think one of the things to be concerned about is that, they're in a vulnerable state. So there's a health concern about the child or the young adult, but they have to figure out how to manage the behavior, and it's, a new environment, and they're worried that the medical staff doesn't know much about autism, so they have to sort of keep repeating all the information about autism. So parents and families can come in, or patients and families can come in, very stressed and with a lot of anxiety. I think the other thing too is that suboptimal experiences may sort of reinforce those negative perceptions about the medical system. We always say if you've had a bad visit, it's really, really hard to get somebody to come back through the door if something didn't go right the last time. They see it as a negative environment, and it's really hard to turn that around. So one of the things we always say is end on a positive note. You may not do the full exam, but at least you end on a positive note. And then a lack of a medical home for a lot of families is going to result in high utilization of the emergency department. I think we've been fortunate with a lot of our CAS patients who are insecure in their ongoing care that we have very low utilization rates, which is very good. But I think a lot of families and patients and families sort of opt for the ED because they don't get embedded into primary care, and we really need to increase that option for families. I think potential difficulties for patients also is that, the clinic's a foreign environment, and it's really outside their standard routine. It's got all these sensory demands, and there's noise. And like Dr. Hanks said earlier, there's babies crying. And I will tell you today, I think there was a steady stream of babies crying in our clinic. So for patients with autism, that can be really uncomfortable. And that's where you want to do those small accommodations, like, get them out of the waiting room and into a clinic room to be roomed as quickly as possible, or to do registration there, or maybe make them, have them come in at a time when maybe not so many babies are in, if that's possible. Some other things are anxiety. I mean, that self-regulation that a lot of patients have to do while they're in the clinic can be overwhelming. So while you might see a patient attend to the exam, the fallout from that self-regulation with that patient on the way home for a family can be really intense. So again, that's the kind of opportunity, that's the kind of experience that may make a family hesitant to come back the next time. So having those discussions of how did that exam really go, even after you left the exam, can be very helpful for some families to, again, give you that information so you know maybe what you can change up the next time to make the process a little more simple. Behaviors is another thing. Again, you might see some of these outbursts happen, but again, these are really a form of communication for many individuals on the spectrum. It's not negative behavior, it's really a form of communication. So some approach to exam ideas we have are, one of the things that really works well is to gather as much information before the appointment as you can. Like Dr. Hanks said, we have an assessment process that really helps us to identify, what are the things that we should look for, things that we should avoid, and experiences that the patients had in a medical setting before we actually see them. Don't rush into an appointment. A lot of times that can be sort of, abrupt for a patient. So you want to sort of take your time and keep it as relaxed as possible. You always want to ask the patient and family support team that are there with the patient for advice on, the exam approach. We have used this many times with Henry, where we have actually, done blood pressure or stood in an X-ray environment so that he can see us go through it, so that he understands it's not going to be painful, and it's a fairly simple procedure. So you want to bring them into the exam as much as possible. We've also found that, having a firmer touch rather than a softer touch is better. A lot of individuals with autism, if they think that you're showing some fear or uneasiness, or that you're hesitant, it will maybe make the exam not go as well. So I think being confident and, being calm and settled in your approach is much better. One of the other things we talk about too is, the wait and pause effect. For a lot of individuals with autism, that processing of language can be on a bit of a delay. So if you ask a question, a lot of times if you're not getting a response, you might want to just sort of wait and pause and give them that moment to really process what you've asked so that they can elicit a really good response for you. If you rush through that, it could cause some anxiety. So again, sort of being able to read your patient can be really helpful. Adapt as needed just means, it doesn't have to be your standard exam. You might have to adapt it or modify it, but if you get through some things and you end on a positive note, that's a win for everyone. Communicating with the patient, one of the things we talk about is, speak directly to the patient. Even for Henry, who's not going to answer your questions, we, speak to him directly because he is the patient, and then we will sort of help fill in as needed. Offer choices so that, again, they become a part of their care environment. Avoid jargon because, again, that's a language that we don't understand as non-medical team members coming in. And then pause frequently, again, to give them the time to process what you are talking about. The other thing we talk about, too, is to accommodate as needed. Again, doing that adaptation as needed so that you can make that a really good appointment. I think one of the other things that we would like to sort of talk about, too, is, people first language. So in Henry's life, he's a patient with autism. He's a young man with autism. We always defer to person first language so that it's the person first and then whatever the diagnosis might be afterwards. And you may be corrected by a young adult who prefers to be termed to be called autistic. If they correct you and that's how they prefer to be referred to, then go with it. I mean, we always defer to what the patient would like, but I think to start off to do people first language first is always the best approach. Hey Chris, I don't think I'm working. Oh, there we go. Well, sorry about that. I sort of jumped ahead. So patient and family-centered care, we sort of touched on this, but again, you want to make sure that you involve the family in the care approach. Again, they can be really good to use as models. And here's a picture of Henry as we were doing some of the x-rays with him. Again, you don't want to judge behavior as bad parenting or a bad patient. A lot of times it's just going to be communication. Building trust and rapport with a patient can take you a very long way. One of the things we talk about with Henry is that if you give him a high five, he will know that you're a service provider because he's been high-fived his whole life. But if you do an elbow bump, he knows you're on the inner circle because that's one of the things we do with him when things are going really well. We do an elbow bump, and we don't do it very often. If he gets it from you, that he knows you're on the inner circle. And again, that's where if you work with a family, you can learn some of those tips and ideas to, again, help you to establish that trust and that rapport quickly. And then I think it's really important to be an advocate for the patient, ensuring the next step in care and that they have the full information about the patient will help to ease that anxiety of having to repeat my story again to the next person that I'm going to go see. But I think instilling confidence in the patient and in their support team can go a long way. Saying simple lines like, you're doing a great job, you can do this, you're asking great questions, again, makes everyone feel like they're a part of the team and makes them feel like they're active in the care environment. Encourage self-advocacy. You have a standard check-in process. Are you having patients, do that process? Encourage them to hand the insurance card, hand their ID over when they come in to check in. Also, you want to encourage them to say no if they don't want to do something in a procedure, or to make follow-up appointments. You really want to encourage them to be involved in the next steps of care as much as possible. Data is very important in care, and I think in the field of autism, or in the world of autism, one of the things that we've learned is that data can really help drive medication choices, behavior management ideas. Do we do melatonin for sleep or do we not do it? And there's all sorts of ways that families collect data. There's apps. There's you can just write it down in pencil and paper. There's sleep logs. There's medication logs. I know that even right now we're actually Henry has a tendency to point to his head and say sand, and we're not sure why. So we're actually tracking that to see if we can see if there's a time of day where he says it, if it's after he's eaten anything, so we can determine why is he saying that, because based on that, it might point us in a direction of some kind of care or some kind of medication that he's taking. Again, I think if families come in and they're not sure about things that are going on, have them collect data, because it can be very helpful in driving the next care option. And then things to think about, each patient with autism that walks in your door is very unique. So your approach to care is going to be different. So this is a great opportunity for you to be flexible and be creative in how you're going to provide care to that patient. And then the other thing I would like to say is don't let autism rule the care. Meaning, when Henry was very young, there were times where he was very quiet and very calm and very snuggly, and I just thought it was the best thing ever. And then I realized when he gets like that, he's actually spiked a really high fever. So we just assumed it was part of autism, but it wasn't. It wasn't one of the aspects of autism with him. It was actually, he had a high fever, and it was something that needed to be addressed. We had a patient when I was at Children's who came in who usually was very, very quiet, but, we never really thought anything about it. But one time when he was in the office, he was very quiet, pretty standard, appointment. And then we went on to find out that he actually had a massive ear infection that landed him in the hospital for 3 days. So again, you don't want to just assume that it's an aspect of autism. It actually could, be that the child's very ill and something needs to be addressed. And then handling the unexpected. These things will happen where you'll have the patient who does get upset or things aren't going well for them. And, a couple things. You want to stay calm. You want to bring that whole care team that's around that patient into the situation and ask for advice and guidance. Take cues from the patient. Do they need to take a break? Do they maybe need to get up and walk around? Do you maybe need to end the exam and schedule another one for the next part of it? Offer options to, again, handle situations that may not be going well. Provide incentives. I think that's one of the things that we talk about is, what's sort of the reward for doing really well in this appointment? And, what is something that maybe you can offer in even in your office environment for that? And again, when you have a lot of, some negative behavior that crops up, you just want to ignore it and try to keep focused on the positive and moving forward. And then other strategies. Again, if you can room them immediately or find a quiet room for when there's, a lot of noise in the clinic, that's always helpful. Make patients first of the day or first after lunch so you can avoid long waits. Medication flexibility, and that should say pill, not oral. Is it, do they prefer a pill or a liquid? A lot of times that can help with, actually taking the medication. Ask the parent for guidance. Pre-visit walkthroughs are a great idea. Again, for a patient who's never been to your clinic, if they can come and see the environment before they actually come in for the exam, that can go a long way to making the exam go much more smoothly. Quick registration so that you can get them roomed and, very quickly. I think one of the things that we do at CAST that has been really very beneficial is that we huddle, twice a week. And those huddle discussions are great. We talk about the patients who are coming in, so the providers are a part of it, the MAs are a part of it, the nurse, the social work. We're all a part of those discussions to see, what do we need to maybe notify the front desk about, or any special accommodations that need to happen, or maybe what happened at the last exam that we want to make sure doesn't happen at this exam. I'll give you a good example. We had one patient that was coming in for shots, and it said in the notes, when she arrives, do not say the word shot or she will leave. The one person missed the huddle that day, and she said, "Oh, are you here for your shots?" And she turned around and left. So huddles can be a great way, again, to make sure that the appointment goes as planned. Again, include families and then the patient in all aspects of the care. And I would really recommend staff training in autism as much as you possibly can make that happen. On this last page, I just have some websites and some research and some other resources that you might want to take a look at. There's a lot of things that are out there that are specific to medication or to sleep or to transition, those kinds of things. So you might want to take a look at that. And there's a lot of new research that's coming out on autism that's always kind of fascinating to keep an eye on that as well. And then again, our website does have some videos and some resources and several publications, and we're going to be updating that on a regular basis. So if there's not, if you check now and always come back and look again. And I think we're at questions.
Yeah, so.
All right. Sorry.
No,
I was just going to thank you guys so much for a wonderful presentation. I think you gave us a lot of really good considerations and just a lot of good strategies that I think can be incorporated into a variety of clinical settings. And I was just going to say, if people have questions right now, if you can look at the gray control panel that you each have on your screen, there's a little questions tab, and you can click that and type in your questions. And as they come in, I can read them to you guys, and we can address them as they come in. Does that work for you guys?
Yep.
Perfect. So it looks like we have one right now that says, how do patients with autism usually do with physical therapy?
That's a good question. Amy, I don't know if you've had any experience with that. My experience, I've never been there when it's happened. You know, I'm in the office, but I've sent a good number of patients to physical therapy. It's, of course, it's, you know, wide and varied from patient to patient what they need. I've had good success in getting people the therapy they need. Sometimes we've had to do it through home care companies and get a, you know, physical therapist in the home. But I've had plenty of patients do well in you know, the therapist's office setting too. I think, you know, when I refer someone to therapy, I always make sure that I include in that referral information about, you know, the patient that the therapist may want, as far as, you know, what are they going to tolerate? What do I, you know, how do they communicate? Who's going to come with them? And then make sure, you know, if it's someone that, you know, normally goes with support personnel, help the support personnel understand what they're going into so they can be prepared. I don't know, Amy, have you had any experience in this?
Yeah, I mean, I think one of the things that I would suggest is that if you're concerned about the patient actually getting through the actual physical demands of the physical therapy session, what these are suggestions I would make is, you know, I would send, and I would have somebody else go and actually go through all the motions and maybe videotape some of that so they can, again, see the environment, see what the demands are going to be, see what some of the physical movements are going to be, so that, again, it builds that familiarity. I mean, again, anytime you're going to have a patient to go into a new environment, you want to see how much familiarity can I give to you before you actually go in. So I'll give you an example. When we did braces with Henry, we watched a lot of YouTube videos on braces. We went and we had, her sister still had her braces on, so we watched that process. So he knew all about braces before we actually went to put braces on. And that actually, and it made getting braces on go really, really well.
All right, it looks like we have another question also. It's, have either of you ever considered using e-consults to support physicians that have one or very few patients with autism? And could community experts be added to the medical team?
Yeah, so the e-consult approach has only recently been kind of rolling out in our institution. When we've looked at it, it's been successfully used for a few specialists in our area, and I'm certainly interested in the concept. Currently, within, you know, we're in a large academic institution, and so we definitely get people reaching out to us saying, "Hey, I've got a patient with autism that's experiencing this or that, and you know, how would you approach it?" And so we kind of provide that on an ad hoc basis, but it's not formalized. I think it's a great opportunity. As I said early in my talk, you know, one of our biggest barriers to successful care is lack of provider comfort. And as Amy said, a lot of that is not just the physician provider or the, you know, therapist or whoever, but it's all the staff in the office. And so I think there's a lot of merit to the e-consult, but I also think there's a need for training, you know, that gets outside of just the one, you know, the provider that's asking for the consult, if that makes sense. As far as community providers, really important. That's kind of our next step in our process of developing our clinic approach. Is we are now trying to think about how do we start reaching out to others in the community, other doctors, you know, and other providers, and provide support for them. But we're still working on those processes. We've developed some of them, but they're being piloted right now, so it's a little premature to talk about them. Amy, anything to add?
Nope, I think you've got that one covered.
All right, we have another question, and it's pertaining to the assessment tool that's on slides 21 to 23. I don't know if we're able to click back to those. And the question is, do you know of any standardized assessment tools that are used to encourage appropriate use of pre-op and intra-op sedation? They said that they're asking from a dental treatment context, but are thinking about evaluating the treatment capacity and need for sedation. Just saying that it's relevant to many fields.
Yeah, I don't know if this is the right slide because my slides aren't numbered, but
let me see if I can find it on mine.
Actually, I can probably figure it out. 21 to 23, yeah, okay. So this area. So that was a big question. Interestingly, I think the dental literature is farther along in thinking about how to care for individuals with autism and other developmental disabilities than the medical literature is. There's very little in the medical literature. So I'm not aware of anything specific related to preoperative evaluation. I can't say I've looked very much for that. So I can't. Can you read the question again? I want to make sure I'm answering the right thing.
Yeah. Do you know of any standardized assessment tools that are used to encourage appropriate use of pre-op and intra-op sedation? They're asking from a dental treatment standpoint.
Yeah, boy, I don't. I'll have to look around a bit. But I've not seen anything specific to developmental disabilities on that manner. No, sorry.
I would say, so I don't know if anything's standardized either, but I will say that when I was still at Children's, we worked with the surgery department, and we worked on a sort of a pre-op assessment for patients that were coming in, because about 10% of the surgeries that they do at Children's involved a child with autism. So if you connect me by email, I can probably connect you to the person who actually we designed it with, and I think it's still in use in the surgery department over at Children's.
That's right. I forgot you did that. And a lot of it, a lot of that comes back to, trying to anticipate what are going to be the challenges going into and out of sedation, and how you're going to support and help the patient during that time. So similar to what I've got up on the slide here, of course, you need different questions, but really just thinking through the steps and getting a plan together.
All right, the next question, oh wait, hold on, is this a follow-up? Okay, the person who asked the question gave their email. I'll send it to you guys afterwards.
Okay.
Another question is, one barrier to access to care is financing the care. In transition, this is problematic in dental services. How can we address this as a healthcare community? Another big question.
Yeah, that is a big question. So number one, so insurance, of course, every different insurance pays different, as we all know. We take a wide range of insurances in our clinic and just deal with the, so about 30% of our patients are on Medicaid, 30% are on Medicare, and the other third roughly are on other private insurances. I think, I don't think we see as many gaps in insurance for medical care as you probably do in dental, especially since Obamacare, with the change in the age to 26. We're not seeing a lot of that yet, and by the time people are 26, they've either normally got some other source of it. So we're seeing less of that than we used to. But insurance changes certainly create challenges. As people shift from one insurance to another, the providers that are available to them may change, and the medications available to them often change. I think, that to solve that one is really a large systemic issue. I don't know. I'm talking too much with no answers. Amy, what do you think?
I don't know that I have any great answers either. I mean, I know that I've done some work with dental here in the state of Ohio, and I don't know if the safety net clinics, if that's something that might be an area where you can sort of double up on appointments to give. I'm just kind of assuming that you need more appointments for patients to sort of get through the dental process. I know at Ohio State, they see a lot of patients who are Medicaid-based patients and don't have insurance either. So they might be a really good resource to answer some of those questions.
And I think as I think a little bit more, when you think about the transition process, the reason we use the word transition is because it's not a one-step thing, and ideally starts early and is, the person's well prepared before they move on to new settings, and that's where, hopefully in a pediatric setting, that kind of thing is being discussed well ahead of time to say, all right, at what point is insurance going to be a barrier, and how are we going to address that well before it becomes a barrier? Because as with anything, whether it's dental care, whether it's, I need medications for this, or I need a doctor for that, if there's no insurance, it's a huge barrier. And so making sure there's good pre-planning, I think, is the most important thing you can do there.
All right, I think we have time for, oh, sorry.
Okay, no, go ahead.
No, go ahead. I didn't know you weren't done yet.
I was just going to say, when you look at all the literature and guidelines on transition that is out there, it often talks about starting transitional conversations as early as 11 or 12, at least to start the, building a background. And I really think by age 16, you need to be, starting to plan for what adulthood is going to bring, and recognizing that, not all plans are perfect, but very clearly, all the experts in the field are suggesting starting young, starting early. And so, you're not trying to put all this together at the last minute. That's it, Jessica, go ahead.
Okay, we have one final question before we wrap up. It's, in what ways, if any, have you been able to integrate insights and approaches at the CAST clinic into OSU medical and nursing education?
Boy, Jessica, do you want to answer this one? She's done a lot of work on this, but no, so let me make a couple comments. We have, one of the greatest experiences we had is after we've been doing CAST for a couple of years, one of the docs that works with us was mostly based at a different clinic, and realized that traveling between the two clinics was really hard and exhausting. And so she decided to take all of her patients, to that other setting. And I thought it would go well because I'd worked in that setting previously and, knew the people there and thought it would go smoothly, but they were really nervous about taking on this new patient population. And so we had the opportunity to take what we learned and a lot of the stuff we've talked about and sit down and do a training with them and kind of talk through approaches and plans and provide ongoing feedback over time. And it really has gone smoothly. Now, we haven't done it system-wide yet. The OSU Medical Center is a large system. There's a number of different people working on this. There's some folks through our USED that are working with the emergency department. And honestly, like I said, Jessica, that's leading this. Do you want to comment at all on what you've been doing? Because she's been working hard on that, actually. So.
We've actually done, we have an initiative through the College of Medicine that we've actually been working on with a grant from the American Academy of Developmental Medicine and Dentistry. They have a program called Medical School Partners, and we're in cohort 2, and they choose a number of medical schools and actually provide funds for these schools to add education into the curriculum about intellectual and developmental disabilities. So we're actually at the OSU College of Medicine in the process of working on some curriculum development and adding content, so introductory lectures in the first 2 years of medical school, as well as adding physical exam tips and tricks and kind of some examples of this for students before they head into their clinical years. A practice simulated patient experience in an actual kind of practice clinic setting where they actually get to work with individuals with a variety of disabilities. And we are also have just finished developing an advanced competency that fourth-year medical students can participate in. And one of the clinical sites for that is actually the CAS Center, which we're very excited about as well. So that's one of the things that we're working on, as well as several other medical schools throughout the country, which we're very excited about.
So yeah, I mean, I think to summarize, it's a work in progress. We've kind of taken the one clinic and one setting at a time approach. But it's going to take a lot of time and a lot of effort to work through all the different settings. We still struggle with inpatient care and places like that, but we're hoping to get there eventually.
All right, so I think that's about all that we have time for tonight. Thank you so much for this presentation. I think this was really helpful. Do you guys have any other closing thoughts before we end the grand rounds?
Amy, any closing thoughts?
Yeah, I mean, I think in relation to that last question, I mean, if you have interest or you would like us to come and, work with your department or your division, just always reach out to us. We're happy to do that. And we do have family advisory councils who actually are on some of these med panels for the med school. So if you ever go to any of those sessions, you may see some of our our family members represented.
Yeah, and I think my closing thoughts would be that kind of jumping lines of thought a little bit here, but one of the things I've learned in the last few years of doing this is that, when you approach a patient, regardless of their situation, thinking about the long-term view of, if you go back to a lot of things Amy talked about, what you may accomplish with other patients in one visit sometimes takes many visits. I like to use the example of, complicated things like a pap smear in a woman. It often takes multiple visits for us to get to the point where we can accomplish that. But recognizing that by building those skills now, if something bad were to happen later, we could address it when needed is important. And so, when we think about transition, a lot of it is planning for future health needs that may not be present now and really thinking about the long view. So that's where we're trying to go.
Sounds good. Well, thank you so much. And thank you to everybody for attending, and have a good evening.
Thank you.
Thanks so much.
Take care.